So thank you, everyone. It is an honor to be here today. I'm coming from the other Washington, a little colder than here, actually, but I'm based in Seattle, so unfortunately just here for a day, but so grateful to have been here for the earlier talk. I had no idea that we were going to already have covered donor human milk so much, and I'm sorry that not everyone can stay through the entire day, but I think hopefully connections will be made and fostering some future discussion around policy changes, role of ABM, role of our local policymakers. I'm not quite clear who's sitting here in the room versus who's on the list, but I do hope if there are questions, you're more than welcome to pause me at any time and we can discuss. So as mentioned, I am an associate director with our Maternal, Newborn, Child Health and Nutrition. That's a huge program, at PATH, which is a global health nonprofit. I have no disclosures, do we? It's a global health nonprofit that's based in Seattle, Washington. We also have an office here in Washington, D.C. But the focus that touches on so much of what PATH does is around equity and access, whether we're talking about vaccines, drugs, basic health care, or human milk, which is the interest of those of us in this room today. This is a slide I just love because just imagine a world where we were done with what we're talking about today. Equity is in place. Every baby has access to human milk. It's easy. That mom is supported. There are no disparities. Imagine. And that's what we're all striving for. It requires multi-sectoral approaches, cohesiveness, collaboration. It is a nonpartisan issue, should be, and requires a global effort, really. So at PATH, our focus primarily has been in resource-limited settings. We are not a hospital. We have many medical doctors who are at PATH. The lead of our program is a practicing neonatologist from UNC and University of Washington. But really, we're trying to think more broadly along the public health spectrum. And our focus primarily is women and children. But of course, that's a misnomer, actually. How can you support women and children without focusing on the entire community and the men? So, we acknowledge all of that. But why women and children? Obviously, our job is not done. We have technology innovation. We have the world shrinking, and yet children are dying. Women die in childbirth right here in this country. If we invest in women and children, we know that families are healthier for generations to come, and it makes communities and countries more prosperous, which actually lends support towards global health security as well. So PATH, just to position, why human milk? PATH is a large global health organization that focused initially on technology innovation, really looking at reproductive health technologies. How can we make technology simple and accessible and cheap? And so through public-private partnerships over the last 40 years, PATH has been working across vaccines, drug development, diagnostics, simple diagnostics, temperature indicators on your vaccine modules that everyone has seen, but they were developed by PATH years ago. A number of devices, safe water, and then system and service innovations. How do we actually get all of these things to the people? What good does it do if you innovate this fancy technology and it's not the right price and it can't get that last mile to the actual users who need it? So that's kind of where our program that I'm based in comes in, and our role around supporting women, supporting policies around breastfeeding and provision of human milk. This is the reality that although maybe this group might be focused primarily on domestic issues, even in this country, women are giving birth in diverse settings, right? One hospital is not comparable to the next. Take that to the global level, and that's extreme polarization in terms of what women have when they're giving birth. Neonatal care. NICUs, if you've been in a NICU in Mumbai, compare that to a NICU at Seattle Children's, quite different experience. And diverse breastfeeding environments. We face this in our own backyard, recognizing that there's quite a range in support and protection and safe places for women to breastfeed. So recognizing all of this and putting it into the context of there are a million priorities hitting these communities. If you're a mother in rural India, is breastfeeding a priority for you? You've got 5 children you're trying to keep alive. You're trying to deal with safe water, income. How do you manage breastfeeding? So where does it fit in the grand scheme of today's woman, today's family, and today's children? But no matter what, we all agree in this room, every baby, and I'm going to specifically be focusing on neonates, they have the right to receive optimal nutrition. And we acknowledge that that's a mother's milk. So current data, although promising in terms of child health and a decline in the under 5 mortality rate, we've made some changes over the last, since 1990, and projections are pretty positive that we're going to keep seeing decreases in under 5 child mortality. What's happening, though, is that there's a slower decline in the neonatal period. And increasingly, although the overall numbers might be shrinking, the proportion of those deaths are in that neonatal period. Meaning that, what are we doing in those first critical hours, critical days, critical month of a newborn's life? What are we doing? And what are we doing wrong, maybe? We know that one major leading cause of neonatal death is prematurity. 15 million babies are born premature every year. 1 million of these deaths are from preterm birth complications, and the majority of these take place in Africa and South Asia, where they're certainly not going to be facing, the majority of the women, high standards of care in their routine health care. What's frustrating to everyone in this room, and I think this slide is probably known to all of you, is that 75% of newborn deaths could be saved. We actually know what to do. There's no surprise, and many of these are not high-tech, expensive interventions that require surgery, or they're basic. They're essential care during childbirth and the postnatal period. It's antenatal steroids, kangaroo mother care, and antibiotics. And we know that if we could at least, if these interventions exist and yet they're not actually reaching the very populations that need it, then there's a systems failure. It's not that we don't have the tools at the ready. Somehow the systems are failing these babies and the women. The focus of this talk is really trying to hone in on essential newborn care and where does breastfeeding fit within that. The Every Newborn Action Plan really spells out that all of the key components of essential newborn care, hygienic care, thermal control, newborn resuscitation, and support for breastfeeding are all considered equal priorities in terms of how you care for these neonates. This is an important aspect for us to consider because I feel too often, and I'm sure I'm speaking to many of you who feel the same, that so often we feel like we're preaching to the choir, right? We're at a breastfeeding meeting, we're speaking to other breastfeeding advocates, and then it's just this cyclical situation. However, if we shift that and now we're placing breastfeeding square within newborn care, and we're talking instead to neonatologists, pediatricians, policymakers dealing with newborn care, then we've actually broadened our pull and the potential for real change in this area. And so for us, that's what we're trying to do at PATH. We have quite a broad focus on expanding newborn care and expanding breastfeeding support. What about linking the two and pushing breastfeeding really to be considered as a medical intervention? This is a first food. It is an essential medicine for these babies, and phrasing it that way. And so we know, obviously, no one organization, no one group can do this alone. ABM is a member of the Global Breastfeeding Collective, which is an amazing movement that is comprised, it's led by WHO and UNICEF, comprised right now of 20 organizations, several in the room, hopefully to grow. But I feel like for once, or it seems like what's happening is you've got a range of organizations coming together, trying to think openly and honestly, What hasn't worked? Okay, the world is different today. Women are working. What about those messages that we've said breast is best for years? What is not working for today's woman? What can we do? And it's not all about that woman. It's not a one-woman job. We need to push on policies for the employer to provide safe spaces. We need to educate the men. We need to create these safe systems for the women. And this is not just looking at the U.S. setting, but globally. What can we do in Kenya, working with the informal industry? What can we do in Bangladesh, again, working with the informal industry, so that women are giving safe opportunities to pump and continue breastfeeding their baby. So it's through groups like this that then we become more powerful. Any one group is far too siloed. If we're going to make any inroads from a policy perspective, we have to come together. But what I kind of want to have us focus on from my talk is, how do we know what we're even measuring? We have the traditional indicators to see, okay, how are we doing with breastfeeding? Okay, exclusive breastfeeding to 6 months, that's one. Another is measuring the early initiation. How are we actually trying to identify if breastfeeding within the first hour is happening? We know that globally these data are not good. That's where we're struggling. Even as exclusive breastfeeding rates might be increasing, rates at discharge and duration of breastfeeding, it's this early initiation that we are really, as a community, something's wrong. And I will push that a little further to say that maybe something's wrong even with the indicator that we have. Is that indicator enough? When you're talking about a NICU setting, are we getting at, okay, did that baby receive breast milk? Yes, no. Do we get at why? Was the mother supported? Were there systems for storing the milk? Was the staff educated around how do you express milk for a mother of a preterm, for a mother who's sick, who just had a C-section? Very specific situations exist in a NICU setting, and have we done enough to really document why this indicator is not being moved as we would have hoped? So we do know that 77 million babies waited too long to be put to the breast in 2015. Only 45% of newborns were breastfed within that first hour. And you would think this is where we actually have power, right? This is where we have the mom. We have her in the facility usually, often, not globally. But if we can't achieve this now, how do we expect we're going to achieve a breastfeeding community beyond that facility level? So we really have to start in our own networks. So, and globally, this is the same situation. Some countries doing better than others. But, I really want us to stop and ask a question. If both nutrition, breastfeeding, and newborn health are priorities, they are considered to be priorities on the global health agenda. Certainly SDGs reflect that somewhat. But are we meeting the need, and are we asking the right question? So for example, for a preterm infant whose mother may be housed at another facility, the baby's been brought into a tertiary facility, for some reason separated from the mother, cannot access that mother's milk, at least in the first few days. What do we do for that woman? Does every hospital have a system in place to care for that baby? What about the baby who's been abandoned or orphaned? What do we do for those babies? We say human milk is the ideal option, but for these babies that don't have access to their mom, whether at first or long term, are we really meeting the need? And I would say absolutely no. And I like this image because I think this is why. You can think of this bridge as one arm of it being the newborn field, the other arm being the nutrition field. And so traditionally, and I will say PATH as a global health NGO is guilty of this previously. We'd like to think now we're trying to bring it together. We're trying to create a little bridge in the middle. But you've got your newborn policies and your newborn interventions on one trajectory. And that's including from funding, policies, everything, down to your healthcare workers and who's trained on what. And then you have your nutrition teams, your breastfeeding advocates, your dietitians, your IBCLCs. And they're over here. And this is also funding and policy related with their own indicators, their own interventions, and often the two don't meet. often what we see is that your newborn people have never sat with the nutrition people to figure out what is happening in their system. The newborn people are thinking about all these other interventions and all these other issues related to newborn care. The nutrition people are thinking about how do we get that mom to breastfeed? What are we, exclusive breastfeeding, breastfeeding at discharge? What about the sick and vulnerable small babies in a NICU setting? And we are absolutely seeing this disconnect at policy levels, at funding levels, at implementation levels. They just have not been as cohesive as they need to be. And who's paying the price? It's the moms and the babies. So what we have found, sadly, we actually don't know globally how many babies even need donor human milk. That number is not known. The indicators that we have, again, are not clear. We don't know how many babies receive donor human milk. We don't know how many babies receive milk from a milk bank versus just shared. We don't know how many mothers receive milk because the nurse just took it from the mom next to the baby, didn't tell anybody, and just gave it to the baby because she knew breast milk was best. We don't know how often it's mixed with the formula and what that dose response is. We actually do not know these data. And for this group, especially in this room, I hope you pause and realize that is ridiculous. How do we not have that data? What do we know about the true impact on neonatal health outcomes with accurate infant feeding data? What we know is just based on when we've walked into NICUs around the world, multiple countries, and just asked the neonatologist, okay, look around, tell us the babies right now, the snapshot, how many babies need donor human milk? Whether it's because the mom is separated or sick or abandonment or being orphaned, it doesn't matter if it's long-term or short-term. Roughly, estimates are all over the place, anywhere from 15 to 40%. They'll say, well, this baby has nothing. This baby has nothing. So those babies, you can imagine what's the alternative. If there's not donor human milk, they're going to be getting whatever's the standard for the hospital, which, of course, we see a range. Even in the preterm settings, it's going to be, sometimes it's high-end preterm formula, sometimes it's basic formula, sometimes it's bovine, just straight cow's milk. So as a very first, I think if you walk away with any data point, it would be to push your policy leaders, your organizations, that we need this data. We need more accurate infant feeding data in the NICU setting. Donor human milk, I'm not going to go into this. I know a number of you are researchers in the room. We can provide lengthy references for a number of articles that demonstrate the benefit of donor human milk compared to formula. Never, ever compared to mother's own milk. And this is case in point. Donor human milk should never be used as a replacement for mother's own milk. It is sometimes because systems fail the system. But these data are comparing to formula. And so what we know is reduce, for the preterm low birth weight infant, reduced risk of sepsis, necrotizing enterocolitis, as so emphasized earlier. Feeding tolerance goes without saying. This culminates in a reduced length of stay. These babies are less sick, so they're not in the NICU for as long. So they're not as at increased risk for other infections from being in the NICU, but also from a cost perspective, because when it comes down to it, if you're the Minister of Health and you have those competing priorities, you need something that not only saves lives, but it also better save money. And so in the short term, as well as long term, it is demonstrated that donor human milk is a cost-saving strategy. I like to, and I think with all of us in this room, like to think long term, that donor human milk can be viewed as the bridge so that we ensure this baby receives exclusive human milk up to 6 months. And if we do that, that's the real indicator then, the cost savings of exclusive human milk feeding all the way to 6 months. It's not really just looking at donor human milk those first days, but what we know is if formula is fed to these babies for a few days, the moms are less likely to realize the importance, and it just creates this negative trajectory. So as a result of all of this, the World Health Organization has stood beside provision of donor human milk really from the beginning. In 2008, it was at the World Health Assembly, really calling on investigating this as a risk reduction strategy. And as a result of this, really the best guidelines that we point to, although there are a number of other guiding materials out there, is the optimal feeding of low birth weight infants in low and middle income countries. And so we're talking about preterm, low birth weight, orphans, born to HIV positive mothers, severely malnourished, and born to mothers who are too sick to breastfeed. So very strict criteria. We're not talking about the general population. Needy infants, and the number one choice, of course, is mother's own milk. Number two is donor human milk. And you'll see in the parentheses it says recommendation relevant for settings where safe and affordable milk banking facilities are available or can be set up. Now, how many of you think that behind that statement there are actually guidelines for how to set up safe and affordable milk banking facilities? As is so often the case in our policies, we have a nice recommendation like that, but no explanation around how, or no mechanism to even support countries who are trying to set up a milk bank for the first time. So countries are left thinking, okay, wonderful, how do I do that? So thankfully, we have a number of groups that have tried to come to the rescue. The AAP, of course, had an updated policy statement around safety and usage. This is fantastic. There's been a number of things previously, but that this was new. December 2016 really outlined some basic steps to ensure safety. And of course, donated human milk is something that's been around from the beginning of time, right? You all know this. I mean, in all of the holy books, they make reference to wet nurses, whether it's the Prophet Muhammad or Moses, or we know that women have shared milk. That's happened from the beginning. It's the existence of official human milk banks that is relatively new, and yet maybe older than you think. So the first one started in Austria in 1909, and the U.S., the first was in 1919 in Boston. In the UK, 75 years ago, Brazil, the 1940s, India, 1989. The Philippines, I'm not sure when the Philippines, 1996. And then Vietnam, which I'll get into in 2017. Many more than this, but that just gives you kind of a range of the timeline. So although I would imagine most of you are familiar, many people are absolutely not at all familiar with what a human milk bank is. They think they know, but when we dig down, we realize that they don't. To be honest, I think the term is a misnomer. People think bank and they think compensation, and it's similar to a blood bank and a sperm bank, but it is quite different in many ways. However, when it comes to safety and systems, you can think of it comparable to a blood bank. The steps are all the way from donor recruitment. How do you choose your donors? Who is safe through lifestyle screening? How do you collect the milk? How do you screen that milk? How do you store the milk? Big question for areas with limited electricity, obviously. Pasteurization to render it safe from viruses, bacteria, other contamination. Bacterial testing again to make sure that your pasteurization worked. Temperature controlled again while it awaits being distributed. And how do you allocate that milk to appropriate infants? How do you set that criteria? But along this flow of the milk, at every single step, there's significant quality control needs. As you look at this, I'm sure you can quickly imagine at a hospital, if you have a milk bank, you really need the expertise of your microbiologist, your lactation support, your neonatologist, your pediatrician, your food safety person, your quality infection control person. You need all those people to be part of a program like this to ensure safety. But we like to think that a milk bank is much, much more than that. It is not a room where you pasteurize and store human milk. Really, what we can do is think about this as more a hub for pushing a culture to support use of human milk. So really, it's about protecting, promoting, and supporting use of human milk through a number of mechanisms. Not only, if you're saying that your community, whether it's your country, your hospital, your association, is supportive of breastfeeding, then really you need to think about all of these steps, right? Do you have policies that support it? Number one. Have you established baby-friendly criteria and steps in your facility? Are you enforcing the code? How is this even translating to improving optimal breastfeeding practices? And then, only then, when you have all these other systems in place, should a milk bank be considered? We never want, and this is what we hear often in the field, to recognize situations where donor human milk has been used in place of mother's own milk. You can imagine the scenario probably, right? In a busy NICU, there is nobody there who's trained in lactation. You have donor human milk sitting right here. You have a baby who needs something. The mother is struggling. It's easier to grab that donor human milk than it is to support that mother. And so often that is what we see, is overuse of donor human milk. Now, some might say that's okay because it's still replacing formula. But I think for those of us in this room, we recognize the danger in that. And so really we want to think about milk banking being one piece of, sorry, I'm pointing there, but it's here. One piece of this puzzle, that it's really about supporting mothers. And so what PATH is trying to do is work with policy leaders around the world to think about this integrated approach, that really we can think about increasing access to human milk as part of breastfeeding promotion, but as critical to kangaroo mother care. If you're saying that you have a KMC unit on your ward, then what are you doing really around supporting women to breastfeed? Do you truly have systems in place? And then if you have systems that are allowable for a milk bank, do you have one? Do you access donor human milk? And if not, why? So what we have found, where milk banking has been integrated broadly into breastfeeding promotion, that it's been successful. So for example, there's been recent publications that show that implementation of a donor milk is associated with greater consumption of mother's own milk. So it's because, again, you can probably imagine the scenario in a hospital. If women walk in and they say, oh, a milk bank. Oh, here's posters about how to donate. Here's posters about, everything, right? And also posters about breastfeeding. What they walk away with is that it's an entire culture focusing on the value of human milk. And if they go through all of this to store milk in a bank, then it must be important. It's just a perception that carries through far beyond that milk bank. And we also know from publications that when a milk bank is implemented again this way, that it's associated with increased rates of breastfeeding. Not the opposite. We're not trying to replace mother's own milk. We're trying to encourage it. And so I kind of want to maybe take a step back and think about what have we done then over the years. If we know all of this, then where are we? And there certainly has been policy transformation in this regard over the last 10 years. What we know now is that the development in the current, from 2017 from AAP, the development of public policy to improve and expand access to pasteurized donor milk, including policies that support improved governmental and private financial support for donor milk banks and the use of donor milk is important. They're not, in previous times, they often these policy statements would kind of beat around the bush a little bit. This is not beating around the bush. It's very clear that we need to focus more support in this area. The Human Milk Banking Association of North America, which comprises the U.S., Canada, and Canada, has been quite phenomenal to watch. In 2010, there were 10 operational milk banks, which you can see in the upper map. By 2018, there are 27 operational, and 4 are developing. I don't know how many of you are very familiar with Hambana, but Hambana itself operates as an association of linked milk banks to hopefully provide some kind of cohesion around safety and standards and policy, making sure that they can present as a unified front. They also operate independently. They're not linked in terms of financial support or staffing or resources. And so you can imagine the complications that presents when we have an association and not really a nationalized network scenario. Globally, in 2008, this gives you, we don't really know the numbers. I think back then it was around maybe 300 milk banks. And in 2018, we know it's around 600. What we don't know is if this number is in any way accurate, because there is no register or no formal mechanism for connecting or tracking all of the milk banks. We also know that there are some milk banks operating in secret, In Germany, we know that there are many of these that they were there from East German, West German days, and they operate in secret kind of under the radar to avoid any policy issues. So we actually don't have a sense of how many are operating, and as a result of that, how many are operating in an integrated manner. Are they simply pasteurizing, or are they a part of their breastfeeding community? Are they linking in the lactation support, the dietitians, to really try to expand what their role could be? And the progression from policy, I won't read these obviously, but it certainly has increased in terms of visibility. There is now WHO guidelines. They're integrated into newborn care guidance on maternal newborn child health. We have the low birth weight guidelines. This is not enough, I will say, in terms of safety and standards. There are no WHO guidelines on safety for donor human milk. There are no WHO guidelines on ethical use of human milk. Can you commercialize? Can you sell? Can you buy? And so that's a real gap in this field. As a result, countries or hospitals or regions, it's up to them to develop their own guidance. There has been a push and an increase in the development of guiding materials over the years. Probably the one that stands out the most, there are two. It's the HMBANA, Human Milk Banking Association of North America, walks through all of the quality control systems, not how to integrate with breastfeeding, but simply how do you pasteurize and store milk. The NICE guidelines, which are the UK standard, and then a number of other guidelines that have been developed over time, which I'll talk about in a moment. There are a number of associations around the world operating independently, separate from one another. HMBANA, established in 1985. The United Kingdom, established in 1997. In Brazil, established in 1998. The International Brazil Program, established in 2007. HMBASA from South Africa, established in 2008. The European Milk Banking Association, 2010. And in India, an association in India was just established in 2014. I want to pause for a minute to describe a little bit about Brazil. Brazil has created a phenomenal model around integration. So in the 70s, roughly, they really took a turn to prioritize child health, and they had the massive backing of their government to develop an integrated system, fully integrated around vaccines, around nutrition, and obviously breastfeeding support. Pivotal to that was the inclusion of human milk banking. From the very beginning, they established human milk banks as houses of lactation, not as milk banks, as houses of lactation where women could come into a facility. They always knew that that milk bank is where they could get lactation support. They could donate if they wanted to, but they did not have to. That's not what it was about. It was to provide lactation support. And as a result, they developed a linked system nationally, now providing support to over 23 countries, Spanish and Portuguese-speaking countries, around their integrated system. It's been quite phenomenal because they really do, housed in the same facility. It's as simple as having, when you're designing your milk bank, not only having your room for your clean room for pasteurization and looks like a lab, but then attached to it, have a room that's meant for women to come and receive lactation support. It's that simple. And so that's just what they strongly believe. So Brazil is widely held as the global model for this approach for human milk banking, and has definitely informed our thinking and our outreach. They have over 220 milk banks within Brazil alone. I think it's probably more like 250 right now. And then they provide outreach. They consider this, the Ministry of Foreign Affairs and the Ministry of Health consider this one of their top export models. So they export the model to other countries through government-to-government agreements, quite complex, and then they actually physically come in and help even design the milk bank and provide technical support. The frustration is that it's to Portuguese and Spanish-speaking countries. The rest of the world quite literally has been left without. Everyone recognizes that this is a model, but they didn't even have their guidelines translated to English until lately when we had to beg them if we could. So it's an amazing model and limited. So currently, where are we? This is a similar image of what I showed a second ago, but there's roughly around 600 milk banks around the world today. It's not enough. The demand far outweighs the supply, especially when you consider most are in Brazil, right? You've got at least 230 or something there. And the greatest need is in the areas that have the fewest milk banks. Africa. South Africa has roughly 30 milk banks. We're never really sure. Not really managed or controlled by the government, all distinct with varying systems for quality control. There's no other milk bank in Africa, possibly one in Cape Verde, but we're not sure, supported by Brazil. In all of Africa. I mean, how is that possible? India now has an association. They've had a milk bank for over 25 years. But considering that the burden of preterm infants is so significant in India and the Southeast Asia region, it's unacceptable. So why is there limited scale up then? What's the problem? And when we started learning about this, wearing our nutrition and our newborn hat, we were initially thinking that, oh, well, it must be technologies. Maybe there just needs to be simple pasteurizers. Well, that's the easy part. I mean, you can design a simple pasteurizer, but it's far greater than that. Why aren't there standards? So many countries are afraid to even begin thinking about a milk bank. They know it's WHO recommendation, but there's no guidance on how. If I take the Hambana guidelines from North America, how does that fit my scenario in rural Kenya? I don't have the same healthcare system, the same resources. How can I use their guidelines? So we need basic systems for safety and policies to guide how things are implemented. Policies. Why is human milk banking not prioritized equally among nutrition and newborn care? There's so much work to be done in this area. Data. We do not have appropriate indicators around need, documenting what support mothers need, what are we doing in terms of providing these babies food, and how do we actually improve systems? And then integration between newborn and nutrition. And then, of course, innovations along that entire quality control spectrum. I'm just going to skip through a few of these, but PATH has been trying to work over the years by bringing together global experts. People have been thinking about this for a long time, but often what's different is you have not had your human milk banking experts in the same room with UNICEF and WHO nutrition and newborn experts. Shockingly, they haven't really sat together to figure out, okay, what's happening? What are the true gaps in the field? So PATH has been trying to, through working with these kinds of partners, develop systems for quality control and for a framework for how do you develop an integrated system linking with KMC, and it's all about breastfeeding promotion and safety. Again, keeping an image like this in your mind, it's not about a milk bank, it's about increasing access to human milk for all infants. We've been working across a number of regions, and I know the Alive and Thrive colleague will speak later about Southeast Asia. Most recently, we've been working in Vietnam to help the Ministry of Health establish their first milk bank in Vietnam, very much as a piece of their early and essential newborn care. We've been doing the same in India to strengthen their systems so that they have a more integrated model. And we are currently working in Kenya, where we hope to establish a center of excellence for the entire region so that they can have a learning model that's appropriate for the Africa context. PATH does this really through our partners and with a phased approach. Number one, it's about establishing ownership. In the absence of global guidance, trying to understand and see and learn from existing model milk banks is key. So what we have done, for example, is we took a delegation from India to Brazil to let them see that Brazilian model. Of course, they laughed when they walked into the Brazil hospitals and saw how empty their NICUs were compared to what they face in India. However, there are a lot of similarities on the economic front, the funding being put in by the government, and the potential for a nationalized system in India was quite informative. Conducting formative research so that we understand fully what are the barriers. There's so much fear around human milk, donor human milk. What are the issues when you're talking about cross-culture, cross-religion, cross-tribe, and so you have to identify that early on so that your communication strategy can address it. or you work with the right religious leaders or something. And then really working on developing local guidelines, guidance on safety and integration so that it's reflective of the breastfeeding policies in the country, and the quality control is reflective of the resources in the country. Do you have a lab in your hospital? What's that microbiology system like? Does it need to be outsourced? I mean, every system is going to be different. Even how you're screening the donors, there are different perceived risks. You can imagine in South Africa with HIV being at the forefront, the way that they screen might be different from other locations. And then phase 2, we're working to operationalize, actually help to set up the first milk banks so that they are well resourced, that there is a high level of technical competency around safety and breastfeeding protection. And then we evaluate. There is not enough data. Although there's data supporting use of donor human milk, we need further research to document. If you truly have this integrated approach, what is your actual impact, not only on cost, but on how mothers feel supported, neonatal health outcomes, overall child health outcomes, and just the overall feasibility of implementation. So I'll skip over some of this because I want to get to the end. We have a number of resources. I would encourage you to look on our website if you would like to see. There are videos that are helpful if you're trying to show to a policymaker, for example, what is a milk bank. We have from Vietnam, we have a virtual tour that the hospital wanted, that it's actually a 360. You can walk through the milk bank and get a sense of what this might look like. These are powerful tools for decision makers who might have never seen a facility like this. Our ASEAN in Southeast Asia, our Alive and Thrive colleague, I think will focus on this, but there is huge potential in that region. We had an opportunity to bring together milk banks from Myanmar, Vietnam, Philippines, Singapore, and China, kind of a stretch to the Southeast Asia, together at a breastfeeding summit, really, that was held by Alive and Thrive and UNICEF earlier this year. And it was a phenomenal experience, I think, because it was the first time these groups had ever sat together. They didn't even understand how each country was operating their milk banking system and recognizing the need for a regional network. And the more that we can try to establish systems like that, such as Hambana, but importantly link them at the global level, then we can help facilitate learning. There's a lack of resources, lack of guidance. We may as well be connected in this space. And then I just want to close with where we're going. So in March of last year, PATH held a technical working group with UNICEF, WHO, some milk banking leaders, some neonatology leaders, trying to get at what are the gaps in this area. And when I say area, I'm talking now about broader newborn nutrition. What can we do to strengthen this entire newborn nutrition trajectory? And so they came up together with a number of gap areas that could be addressed, that if resources could be put towards developing best practices, training, quality assurance, monitoring and evaluation, policies, and identifying appropriateness for when donor human milk is available, maybe we can have a paradigm shift around use of donor human milk, that it's used correctly, it's part of newborn care, it's part of breastfeeding promotion, maybe it's actually the driver to bring together these groups that often sit at different tables. So we're working together now with these groups to develop these resources that can be available, hopefully globally, with the goal of strengthening systems around the world. And I want to just close with this vision of our, I think, one key deliverable. We're working with the WHO currently to think about what it would look like to develop guidelines on safety. So you can imagine who that needs to be included from the WHO. It's not only the nutrition child health teams, but it is the safety teams, the very groups who develop like the blood safety, the medical products of human origin. And so we're bringing those groups together who, again, often never sit at the same table. And we're trying to conceive of something like this. What about if we at least had minimal standards of safety? Would that help to increase awareness and confidence in donor human milk so that, in turn, policy leaders will then prioritize this as a need in their country and in their region? So I'm going to close because I think I'm out of time, but this slide is more, I think, provocative. It touches a little bit on what was discussed earlier today. What do we know about the ethical use of human milk, donor human milk and human milk? There are no standards, no guidelines, really no policies around what is ethical. So, for example, in Cambodia early last year, there was a U.S. Company who was sourcing human milk from rural, impoverished women in Cambodia, buying their milk, giving them money that obviously they needed, and then bringing it back to the U.S. and selling it. Now, there's no standards in place. They weren't doing anything against the law. However, UNICEF and partners became aware of this, met with the ministry, and tried to provide some guidance, and the government of Cambodia shut down the program. That's to be applauded that the government of Cambodia took a stand so strongly in the absence of guidance. And so something that I think ABM could probably play a pivotal role in is helping to think through with your policy leaders, what is appropriate? When is it appropriate to compensate women? When is it not? Is commercialization, is that what's going to drive innovation? What are the answers here? And so we hope to hold a summit later this year led by a group of bioethicists who are objective to try to really get at these answers, bringing people from all sides so that maybe we can result in some kind of policy statement. So I'll end there with just a thank you and hope to hear some questions or comments later.